Good morning, my name is George Behrens. I'm just thankful for being part of this amazing meeting. I'll be talking about portal hypertension and cirrhosis. Cirrhosis essentially is a scarring of the liver, fibrosis of the liver. 30% of the causes are secondary to alcohol use or abuse, 30% viral hepatitis, and 30% metabolic associated liver dysfunction or steatohepatitis, a cause that is increasing over the years and probably will become the #1 cause of cirrhosis in the United States in the near future. Portal hypertension is elevation of the portal pressure or the pressure in the portal system. In the United States are linked to cirrhosis. However, worldwide, the schistosomiasis is the lead cause of portal hypertension. It's a type of pre-sinusoidal hypertension. Portal vein thrombosis due to tumors, other congenitals also are frequent cause of prehepatic portal hypertension. So this is a picture of the portal system. We can see an affluent of the portal vein, which is the splenic vein, and the foot pipe veins or the bowel veins. They drained, they form the main portal vein, and they go towards the liver. Freely should be going to flow through the liver and draining into the hepatic veins. However, when the liver is cirrhotic, scarring, the pressure increases, and they give you three main complications. These are probably the three things that you need to know. Portal hypertension leads to fluid in your belly or in your chest, named ascites or hepatic hydrothorax, bleeding, gastroesophageal bleeding or variceal bleeding. This dilated collaterals from the increased pressure, trying to drain the vein, the rupture, and they cause major bleeding, or encephalopathy, where the blood gets shunned from the portal vein into the systemic circulation. As an interventional radiologist, we can measure these pressures of the portal vein doing a transjugular biopsy with hemodynamic evaluation. We put a catheter in the hepatic vein and we measure the difference of pressure between the wedge hepatic vein and the free hepatic vein. That gives us a gradient. If it's greater than 5, it's portal hypertension. If it's greater than 10, it's clinically significant portal hypertension. There are other methods that are less invasive. In this patient, 47-year-old female, this is an MRI of the abdomen at T1 post-contra sequence, where you can see fluid. All this black around the liver is free fluid in the abdomen, massive ascites. You can see the portal vein here in this post-contra sequence. Here is the hemodynamic evaluation I was talking about. Catheter in the hepatic vein. We put this catheter with a balloon. We inflate the balloon, and that's the wedge hepatic vein. And then we subtract we deflate the balloon, and that will be the free hepatic vein. The gradient in this particular patient is 40 millimeters of mercury. In this case, we obtain a sample, and with the CO2 program, where it's injecting the CO2, we can see the portal vein here. How this patient will be managed typically will be with diuretics. They will, if they have fluid, if the main representation of portal hypertension is fluid, it will be sodium restriction diet and diuretics, Lasix and spironolactone. If, let's say, that this patient is presenting with bleeding, it will undergo to an endoscopy and banding procedures. We put a little rubber band, and then they estrangulate the varix and stop the bleeding. And beta blockers, that is non-selective beta blockers like carvedilol, is most frequently used now in these days. But like I mentioned before, if there is shunting causing encephalopathy, the patient will need a lactulose and rifaximin. It's two medications that decrease the level of ammonia in the bloodstream and therefore will improve the patient's symptoms. Let's say when these patients fail to have better control of their symptoms, and then either because they have refractory ascites, they don't respond to diuretics, then is when we play a role. We do what is called a TIPS. Similarly, as we did the hemodynamic evaluation, we go through the jugular vein into the hepatic vein. We puncture the liver, we put a wire, and we deploy a stent. Other option for the management of ascites as an interventional radiologist would be the Denver shunt, operator venous shunt. It's essentially a tubing that goes from the peritoneal cavity through the subcutaneous tissue into the jugular vein with a one-way valve. So the fluid, when the pressure in the abdominal cavity increases 5 millimeters of water, the valves open, fluids shift from the abdominal cavity into the jugular vein. Other options are when the patients are bleeding is VRTO. We go from these collateral veins that are connected between the portal vein and systemic circulation. Then we occlude them and escrows them. For the management of encephalopathy, again, that's probably the procedure that we can do, and also we can combine them with the tips. Here is an example of a tips. We go from the jugular approach here, and this is a representation with the stent already deployed. This is how we decompress the vein. This procedure actually decreases the portal vein, treat the portal hypertension. It's not like the rest of the medical therapy or the other options where we actually do is palliate the patient's symptoms. Here's a representation of the needle that we use. This is, of course, a magnification of it. Those procedures are typically done in general anesthesia. These are images of a patient with a Budd-Chiari syndrome, where you can see a heterogeneous enhancement of big liver, really essentially lack of the visualization of the hepatic veins. Here's in coronal view, you see a portal vein, big liver. This patient was presented with major bleeding. You can see all these varices around the esophagus. They're massive. They're coronal images. I will show you step by step how we do a TIPS. We see an ultrasound image. Here's the jugular vein. We access that. We get into the hepatic vein. We make sure that we're in a good hepatic vein. We do the hemodynamic evaluation. We inject a gas. We see the portal vein. This is a CO2 portogram. We identify where the portal vein is. Here are you can see that the flow is reversed and going toward these big collateral veins in the esophageal varices. Then we puncture with a needle. We get into the portal vein. And then you can see when we inject dye that all the flow is mainly going through the gastroesophageal varices. We deploy the stent. Here we are trying to see where we're going to land the stents, deploying the stents right now. Here's dilating the stents. You can see in this particular case, because the tract is really long, we have to deploy two. We deploy the stent, we go in to the varices, and then we plug them. We put a plug, coils, glues, other agents, with the idea that we can control the bleeding on this patient. So what a peritoneal shunt is. So here it is again on representation, tubing, silicone tubing in the abdominal cavity through the subcutaneous tissue drain into the jugular vein, and by differential pressure, I guess, drainage all the sides. Here's the fluid and the ultrasound. On the ultrasound, we put a pillowway sheath, insert the tubing. You barely can see it here, but it's right there. Here's the valve, and then you go to the jugular access. This all in the subcutaneous tissue, and then you connect this access that you get into the neck, insert it in through a pillowway sheath, and then you drain all the fluid. Here is a patient, a picture of one of my patients here with a belly, some fluid on it, and then how it's drained at the end of the procedure completely. So I don't really want to go too much into the indication or contraindication or complication of the procedure, but here other procedures that we perform is balloon occlusive transvenous obliteration. That could be anterior or retrograde. There are complex collateral vessels that can be formed. Mainly it's a gastrorenal shunt or a splenorenal shunt. So here is representation of the portal vein, the splenic vein, IVC, renal vein. Most of these shunts drain into the renal vein, so you can go retrograde from the femoral vein and get access into it, inject the cirrhosis agent. If you want to go antegrade, you can stick the liver, stick the jugular vein, and then go through the liver into this left gastric vein and then inject the cirrhosis agent, or in a combination of both, or you have multiple ways to do that. Here's a case of that, of a BRTO. Here's a nodular surface liver with a large gastric varices, bleeding gastric varices, and this large network of collaterals. In this particular patient, I decide to go through the hepatic splenic artery, drop some coils. You can see the sequence of injection when you see the parenchymal phase, and then how this posterior gastric vein drains into the left renal vein in the IVC. Here a coil is dropped to decrease the inflow into the portal vein. Therefore, the portal pressure will be decreased, allowed us to make a little more easy or successful decrease or embolize the gastric, the splenorenal shunt. We are going here with a catheter into the splenorenal shunt. We put a balloon. We inject contrast. We calculate the volume of cirrhosis agent that we need. We inject it. Here is filling all these collaterals with the balloon inflated. Then we let the medication sit there for a while. 4 or 5 hours, we deflate the balloon. When we think it's safe, we deflate the balloon, and then we see how this is the agent stay there, and all these various are extras. Now we can use this with blocks, coils assisted. There are many ways to do this and make it a little more safe than the old technique that we used to use 15 years ago. Well, thank you very much for your attention. If you have any questions, you have my code there. Feel free to reach out, and I'll be happy to have you in our institutions and a way that you can learn more with us in our portal hypertension clinic. Thank you very much.
Hi guys, I'm here in any case that you have any question. I'm sorry I have a family gathering right now, but I'm happy to answer any question that you guys might have, or anything, any concern, or anything that I can clarify.
Thank you so much. Sorry, go ahead.
Oh, no, if it's okay. Yeah, Dr. Behrens, it's Joji here. How are you doing? Thanks for
I'm doing great.
We definitely want a larger session. You and I have talked offline, but really quickly, I want to know how you built a clinical practice on ascites, not on tips, not on the procedure, but on the disease.
So, well, that's a long discussion. It's a really hard question I don't have enough time to answer you that question. But honestly, I work in a community hospital. So obviously, if you really look, all these procedures are done, the vast majority are done in private practice. 70% of the tips are done in private practice. However, the best results are done in academic centers. So what was the idea? The idea is that you have to decentralize the care. So my thought always been that the issue in liver transplantation is the patient having a really difficult time to get to the tertiary center, because in the most part, they're really far away from where they live. So what I decided to do is bring the transplant center to the community hospital. So I partner with different institutions. So it took me about 4 or 5 years to convince a hepatologist group and a transplant surgeon to come to our clinic, an interventional radiology clinic, and then start seeing the patients with us. So then we start to get all the referral from all the adjacent GI physician group, obviously showing the quality or showing the results that we were doing it. And then along with this partnership, in a period of 7 years, we create this clinic, a portal hypertension clinic. It's not only just for management of ascites. The management of ascites, bleeding, any liver disease. We manage patients post-transplant. So they go for the University Hospital, they get transplant, and then they live closer to our hospital. So then therefore, what they do, they follow the patient in our clinic. So what is important here is not only that you do the procedures locally. No, it's not that we are elevating the level of IR in a community hospital. It's also you're elevating the care in every single specialty, because every time that the patient had a decompensation, the ICU of the community hospital know that they have the support of your support, and they have the support of tertiary center where the patient can be transferred in case that they really need it. So we become you also it's a better communication between a tertiary center and community hospital, and the pulmonologists had to be better, the cardiologists got to be better. Why? Because they know that their evaluation is going to be important for the future transplant of the patient. All the workup pre-transplant of any of our patients is done in our hospital. So the patients don't need to go there or tertiary center to get the lab work, their echo, the cardiac cath, the pulmonary function test, any of that. Everything is done locally. So you can actually see how everybody wins. So the tertiary center obviously make their business doing the transplant per se, but all the workup is done locally. So you keep the money in the local hospital. They do what they need to do in the transplant center, and all the follow-up is done in the local hospital. So honestly, it's an interesting concept. Of course, it's a lot of work. Obviously, I trying to do my best effort to pass the information along and trying to get as many interventional radiologists engaged into this type of practice, but required to be a super specialist. I mean, I dedicate probably 80% of my practice in portal hypertension, and I'm able to do that because I have 12 partners that are amazing. I know each of us, we have our own super specialty, and it's not easy to do that in a community hospital, but it's feasible. If I did it, anyone can do it. As simple as that.
Love it. Love it. Hey, man, thanks for coming out. I know you had other obligations, so I really appreciate you joining us and inspiring the future of the youth, not just here, but globally. We're starting to become a global mission, so I appreciate it.
Anytime, my friend. Count on me. Anything that you need for the future. If you guys want me to give in depth a little more other lectures in these topics, I'm happy to do it. We can develop something how to build up for a particular clinic. I've done it multiple times before, so happy to support, and especially students or people, the younger generation, because those are the people that we need to engage and show them that everything is possible.
Appreciate it, man. Have a wonderful weekend.
You bet. Take it easy, guys. Thank you so much.
Thank you.